you show us the criteria that we example endometriosis mass of the fallopian tube? Could you show us the criteria that we consider to provide start treatment with IVF, or we consider to get surgery before providing IVF treatment? Yes.
Thank you for your questions. I think the first question was about GnRH agonist administration. Am I correct in thinking that?
Yes.
Was that, and how long to give it for? So the meta-analyses that we did in 2019, they were essentially looking at a 3-month course of any GnRH analog that you might consider, buserelin, nefarelin, triptorelin, so all sorts, and we couldn't find a difference. The regimens varied. Your second, so I don't think there is, you know, even in my current clinic at the moment, we don't do long-term downregulation with GnRH analogs for people with endometriosis. The second question had to do with hematosalpinx, am I correct?
The criteria that just providing starting IVF treatment or starting surgery of the endometrial mass before IVF treatment.
Tubal masses, sorry.
Example, the mass of fallopian tube that is endometriosis.
If there is endometriosis in the fallopian tube, well, it depends really, because what the evidence shows is that if there is hematosalpinx or hydrosalpinx, and we think that's secondary to distal blockage of the fallopian tube, then the evidence suggests that stop-injectomy is what should happen before people undergo in vitro fertilization. In natural conception, it's not as clear. We know that there is an association with poorer outcomes, but we know inevitably that by removing the tube, we're automatically reducing the risk of natural conception. So the short answer is, if someone is going to have IVF, then absolutely that tube should come out if there is an evidence that hydrosalpinx, hematosalpinx, because that will increase the live birth rate, which is something that we've published as well on one of our Cochrane reviews. So I hope that answers your question.
Okay, thank you so much.